안녕하세요.
Hello, welcome to the Clear Align Master Course. Today, I will be discussing case reviews. The title says simple case, but that doesn't necessarily mean it's truly simple. Depending on whether molar movement or distalization is required, cases can be categorized as either complex or simple. Today's case is about successfully addressing the patient's chief complaint without molar distalization. So this is the part I emphasize at the beginning of the course. I explain the same process each time: how to make an accurate diagnosis, how to set up an order, how to get started, and how to manage the progress. Today, we will take a closer look at how these treatment steps are applied in an actual case. This is a 25-year-old female patient who presented with the chief complaint of protrusion. However, instead of saying she wanted her lips to be significantly retracted, she wanted to resolve her protruded teeth. She expressed a strong preference to avoid extractions if possible. If you look at the intraoral photographs, you can easily see that both the upper and lower anterior teeth are protrusive. In particular, the upper teeth are more prominent. On closer inspection, the molar-key relationship is a Class 1 relationship. Upon a simple review of the panoramic and Ceph images, no severe protrusion is evident. The patient shows a slight Class 2 skeletal pattern. As you can see here, the maxillary anterior teeth are extruded and also extruded downward, pressing against the lower lip. This contributes to the appearance of protrusion. After identifying these characteristics, the next step is to establish a proper treatment plan. We now need to establish a treatment plan, which involves several analyses. In this case, we are reviewing the Bolton analysis. Since the anterior teeth are protrusive and require retraction, multiple treatment options are considered. The most common approach is orthodontic treatment with extraction. Another option is to do interproximal stripping, which slightly reduces tooth size and creates space for retraction. In some cases, molar distalization may be considered. The first step is to examine the molar-key relationship. If the molars are in Class 1, but the maxillary dentition is positioned forward, the treatment plan should focus on the options such as interproximal stripping, arch expansion, or other anterior correction strategies, rather than molar distalization. In particular, when evaluating the Bolton ratio, it appears that the maxillary dentition is excessively protrusive. In such cases, reducing the size of the anterior teeth may be considered to facilitate retraction. Based on this finding, the treatment plan was established accordingly. First, we confirm the patient's chief complaint, and then we check the anticipated change in the facial profile. Since the anterior teeth need to be retracted, some degree of change in the profile was expected. For the maxillary arch, a reference setup is required. This setup is not created by us directly, but rather by the designer. Therefore, it is essential that we provide detailed instructions so that the setup is prepared in accordance with our treatment plan. Since the maxillary teeth were more protrusive than the mandibular anterior teeth, I chose to align the maxillary anterior teeth with the mandibular position. The space-gaining strategy is the most important in orthodontic treatment. The key question is how to secure adequate space, either through extraction or alternative non-extraction. Only with sufficient space can crowded teeth be properly aligned and protrusive teeth retracted. When we looked at this chart in detail, extraction and molar distalization were marked as not required. Instead, IPR and arch expansion will be used. For clinicians who are less familiar with this type of chart and treatment planning, it can be helpful to proceed step by step, specifying the patient's chief complaint, treatment objectives, and the reference points for retraction. Once these details are written, they can be submitted to the company, and then the designer will use them as the basis for the setup. Additionally, it should be noted that when the anterior teeth are retracted, extrusion may occur. Ideally, the anterior teeth would retract in a parallel manner. However, in reality, they tend to be inclined downward during retraction. So, the bite deepening may occur, and you need to keep an eye on it. In such cases, continuous observation of bite-related issues is essential. Within the treatment planning system, you click on Magic Aligner and then add your comments regarding the treatment requests. You must record the chief complaint. This is essential because there is no designated section for CC. When the designer prepares the setup, they still need at least a basic understanding of what the patient wants. Therefore, the CC must always be included. And here's how I wrote it. The maxillary posterior teeth appeared to be slightly lingually inclined, so uprighting was planned as minor expansion. Based on this treatment plan, the setup was generated. My intention was to achieve alignment using the maxillary central incisors as the reference point. Once this reference line is established, reference point for the maxilla is created. This provides the basis for determining the extent of retraction and estimating the amount of IPR. As shown here, the initial setup was provided, followed by multiple rounds of modification. This is the review stage. After we complete the diagnosis and submit it to the company, we receive the simulation prepared by them. Then we move on to review process. However, you should never assume that the company will handle everything correctly. It is essential for clinicians to study sufficiently and to be able to critically analyze the setup. The more accurately we can diagnose and analyze the setup, the better we can identify errors and determine which aspects require modification. Once the setup is received, the first step is to evaluate whether it has been created according to the intended treatment plan. Looking at the initial maxillary setup, I was not satisfied with the sequence of tooth movement. Although the teeth may move adequately in one step, I was not satisfied with moving the posterior teeth first, with the maxillary central incisors moving later. I requested modifications in this area. In the mandibular setup, the central incisors were planned to move forward. Since some degree of mandibular retraction is necessary for proper anterior alignment, I had originally requested alignment based on the central incisors. However, the setup was prepared according to the lateral incisors as the reference. This really came down to a communication issue. Instead of specifying, please align based on the maxillary and mandibular central incisors, I wrote, please align based on the mandibular anterior teeth. This leads to some misinterpretation. We went through a few corrections when taking a look at the vertical changes. The bite gradually deepens again. Here, the bite gradually increases and then drops toward the end. In such cases, it's important to maintain the raised bite to prevent bite collapse. There's no need to incorporate such downward movement in the simulation. Accordingly, these issues were included in the modifications and a revised setup was obtained. In this version, the final bite was slightly overcorrected, not to the extent of producing an open bite, but about 1 to 2 millimeters beyond the normal range. This overcorrection was applied because, as the anterior teeth are retracted, the bite tends to deepen. This concept was incorporated into the treatment plan, and the result is shown here. When alignment was performed based on the mandibular anterior teeth, the maxillary anterior teeth retracted in this manner. After analyzing the area, more specifically, take a close look at the simulation of the maxillary central incisors. The maxillary central incisors were delayed in movement. Although they could have started from stage 1, they only began moving later after other teeth had already shifted. Movement could have been initiated from stage 1, so I requested that this tooth movement should start from stage 1. This is an example of modification process we go through. Once applied, the outcome changed accordingly. Focus on this tooth here. Looking at the movement of the lateral incisor, this tooth first moves distally and then lingually. These movements represent an inefficient pattern of movement, as ideally they should be retracted lingually. These issues require correction. When retracting protruded teeth, we often first shift them distally and then turning them inward in an L-shaped path. Instead, it's ideal to move the teeth directly inward. These points must be commented to ensure proper treatment progress. Looking at the treatment progress, at this point the patient had completed approximately 6 stages over 2 months, wearing each aligner for about 10 days. The key advantage of the Magic Aligner is that regardless of whether the patient is at stage 6 or stage 10, you can get these interim progress reports along the way. So we can evaluate treatment progress against the original plan and note any deficiencies. As the maxillary anterior teeth are retracted, the bite tends to deepen. To address this, continuous intrusion was prescribed. We review whether these issues are well addressed, and if not, additional prescriptions can be made. Progress reports are available every 6 stages. The plan can be adjusted if any shortcomings are found. Looking at the stage 12, the bite has not deepened further. The anterior teeth are retracting gradually, and overall progress aligns with the treatment plan. Nevertheless, intrusion remains somewhat insufficient, not due to error, but as a limitation of the process. If the plan anticipated a progress of 100, the current outcome is about 50. The current condition is reflected in the report, which then guides us to apply additional measures for better control. At around 6 months, during stage 17, the anterior retraction was progressing well. However, continuous monitoring of bite deepening is necessary. By 6 to 8 months, the treatment was proceeding according to plan, with no signs of deep bite and satisfactory retraction of the anterior teeth. The treatment was completed at 9 months. A review of the results, comparing the before and after records, shows that the anterior teeth were retracted as intended. Importantly, the maxillary anterior bite did not deepen, which can be considered the key point of this case. At the 9-month comparison, the protrusion of the anterior teeth was corrected. The bite deepening did not occur, and mild uprighting of the arch was also observed. Although not clearly visible here, at around 8 months, at-home bleaching was also prescribed. The patient was provided with bleaching material and a tray, which was worn for approximately 2 hours each evening over the course of 1 month. This case also included at-home bleaching. In the final results, the outcome was largely consistent with the initial treatment plan. Of course, not every case proceeds as planned, but like this case, favorable outcomes are also possible. The insights gained here can serve as a reference when facing similar cases in the future. Although categorized as a simple case, it required careful consideration and a structured process. Clinicians are encouraged to follow such protocols in practice, which can lead to successful results. I look forward to sharing further content in the next session. Thank you for your attention.